It's like we're launching a rocket. It's like Central Command.
Pretty much.
Are you ready, Saad?
I am.
All right, good.
So good morning, everyone. Good morning, everyone. We're starting rounds this morning. Welcome. Today's speaker is Saad AlHassani. He's one of our PGY6s in the cardiology training program. Today he's going to be speaking on left ventricular thrombus. So we'll turn the presentation over to Saad and look forward to his talk this morning.
Okay, thank you, Dr. Stadnik. Good morning, everyone, and thank you for giving me the chance to present today at the Heart Institute Grand Round. Today, I will be talking about LV thrombus post-myocardial infarction, and all the data presented here today is focused on STEMI population and more specific anterior MI patients. So I'll briefly take you through the background of LV thrombus, including the pathophysiology, incidence, and predictor of LV thrombus. We will talk about the diagnostic modalities, including TTE, TEE, cardiac MR, and CT, and we'll go through the published data in the STEMI population about these four modalities. And I will talk about the management of LV thrombus. Then finally, we will discuss our data at the Heart Institute. So as with all thrombus formation, Virchow triad, hypercoagulability, endothelial injury, and blood stasis plays an important role in the LV thrombus formation after myocardial infarction as well. So in LV thrombus, is it just the tissue necrosis that leads to LV dyskinesis or akinesis and the intracavitary blood stasis? Actually, in the 2015, the International Takotsubo Registry from 26 centers in Europe and United States found in the stress-induced cardiomyopathy population, the in-hospital rate of LV thrombus have been reported as low as 1 to 2%. Despite the infrequent use of anticoagulation, which was 4 to 8% in this patient population. However, they have a mean LVEF of 40% as opposed to patients presenting with anterior STEMI who have lower ejection fraction. Also in 1990, a prospective study performed to measure the plasma concentration of prothrombin fragments. And in a patient presenting with unstable angina and myocardial infarction compared to a normal healthy population and healthy volunteers at presentation at 6 months as well. And during the acute phase of unstable angina and myocardial infarction, a patient showed increased coagulation system activity, which persists over the subsequent 6 months, with uneventful clinical course in unstable angina or myocardial infarction, but they manifest persistent hypercoagulable states with minimal formation of fibrin as well. So in conclusion, LV thrombus is a result of tissue necrosis, which leads to LV dyskinesis or akinesis with intracavitary blood stasis, and subendothelial tissue injury causing inflammation and collagen exposure, serving as a nidus for the platelet aggregation and activation of the clotting cascade. And lastly, persistent hypercoagulable states and increased coagulation system activity up to 6 months post myocardial infarction. In King's College Hospital in London, a retrospective study was done and analyzed more than 1,000 patients who presented with STEMI and treated with primary PCI to predict potential risk factors for LV thrombus. They reported LV thrombus incidence as 4%, and there was no significant difference in baseline or pre-PCI clinical features between the two groups, and the post-treatment mean ejection fraction between the two groups. The post-treatment mean ejection fraction in patients with LV thrombus was 35%, and in those without LV thrombus was 47%. And they presented a potential predictor of LV thrombus formation, which includes male gender, family history of diabetes, previous coronary angioplasty or stents, lower ejection fraction, longer symptoms to balloon time, anterior STEMIs, glycoprotein 2B3A inhibitor use, and Tamiflu post-angioplasty or stenting. So the LV thrombus remains one of the most common mechanical complication of STEMI in the PCI eras, and impact the management and follow-up after revascularization. And the reported incidence of LV thrombus after MI varies substantially, and it's likely a reflective of variation in the imaging modality used for diagnosis and the timing and frequency of screening as well. And indeed, the use of revascularization techniques has clearly improved the LV thrombus formation rate. And in the thrombolytic eras with two-dimensional echocardiogram, the LV thrombus was observed in 17% of all patients with myocardial infarction. And the incidence also was up to 34 to 57% in patients with anterior STEMIs. And with the introduction with the PCI, the incidence of LV thrombus post-MI has declined to 3% in all STEMIs and still high in anterior STEMI, up to 9%. And in this table is showing a temporal trend in the incidence of LV thrombus as diagnosed by echocardiogram, and the significant decline in the rate of LV thrombi from 1975 to 2020. There's multiple factors driving the rate of the LV thrombus down, including the increased rate of primary PCI, increased use of neurohormone antagonist, decreased adverse LV remodeling, and potent antithrombotic regimen. So there was a meta-analysis of 8 studies with a total of 7,000 patients, collected data of LV thrombi for all STEMI patients, and 5 of these studies documented rate of LV thrombi in the subset of patients with anterior STEMI. 11 studies enrolled only patients with anterior MI. And therefore, the data on the anterior STEMI and this meta-analysis were available in total of 16 studies and in more than 3,000 patients. There was 432 recorded LV thrombi in total, and 200 in patients with all STEMI, and 282 in patients with anterior STEMIs. And among the 8 studies of all the STEMIs, the summary of rate of LV thrombi was 2.7%. Among patients with anterior STEMI, in the 16 studies, the rate of LV thrombi was up to 9.1%. Forgot to mention the modality of imaging used was TTE in this study. And this data extends from 2000 up to 2015. And what is striking is the variation of reported LV incidence between these studies. This table is also from the previous meta-analysis, and it showed the only small minority of LV thrombi was diagnosed using an echocardiogram with contrast. And I just wanted to point out was Dr. LeMay trial, that the only study that used echo with contrast in the STEMI population. Another meta-analysis of 10 studies and more than 2,700 patients, and the incidence of the LV thrombus by cardiac MR in all STEMI patients. They have more than 2,000 patients, and the rate of LV thrombi was 6.3. Excuse me. The incidence of LV thrombi by cardiac MR in all comers with STEMI was 6.3, with 96% of LV thrombus in patient with anterior STEMI. And when only anterior STEMI patient with LVEF less than 50% were considered, the incidence of LV thrombus was 19.2%. They also showed the sensitivity of TEE increased to 70% in those with anterior STEMI and reduced ejection fraction. So what diagnostic modality is available to diagnose or screen for LV thrombi? So first and the most important and easily available and widely and has low cost is TTE. And LV thrombus is recognizable in echo as an echo-dense mass with a margin distinct from the endocardium. The image quality may be suboptimal due to condition such as pulmonary disease or obesity, and distinguishing thrombus from normal trabeculations may be difficult sometimes. Recently formed thrombus can be highly mobile, protruding to the ventricular cavity, as in this slide. Older thrombus tends to have a smooth cavitary surface and is typically more static, and more chronic may calcify and develop central cavitation. For the delayed enhancement cardiac MR, it's more accurate. Cost and availability and technical expertise have limited the widespread use of cardiac MR. The gadolinium contrast will demonstrate uptake within the infarcted thrombi owing the infarcted and to the lesser extent the viable myocardium, but not in the thrombi owing to their avascular composition. On the picture on the left side of the screen, this is a cine cardiovascular MR of the thrombus in the apex of the left ventricle, and on the picture on the right side of the screen, the late gadolinium enhancement imaging confirms the avascular non-enhancing thrombus close to the transmural infarcted myocardium. So this study compared the diagnostic accuracy of TTE to cardiac MR, and also evaluated the course of LV thrombi in the PCI eras. And there was more than 200 patients with primary PCI who underwent TTE and CMR at baseline and at 4 months follow-up. And the study were analyzed by 2 blinded examiners, and patients were seen at 1 month, 4 months, 12 months, and 2 years marks for assessment of clinical status and adverse events. On the CMR at baseline, a thrombus was found in 17 of 194 patients, 8.8%. LV thrombus resolution occurred in 15 patients on the CMR, and 2 patients had persistent LV thrombus on follow-up. Interestingly, on the cardiac MR, there is, at 4 months, a thrombus was found in additional 12 patients. And in multivariate analysis, a thrombus formation on baseline cardiac MR was independently associated with baseline infarct size. Also, this study was of more than 200 patients. They had same-day echo and cardiac MR performed according to a tailored protocol, which entailed uniform echo contrast, irrespective of image quality, and dedicated delayed enhancement cardiac MR for thrombus tissue characterization. And this table represents the diagnostic performance result of the non-contrast and contrast echo. As a result, as well as the CineMR compared with the reference delayed enhancement cardiac MR. Importantly, dedicated non-contrast echo provided a high specificity of 98%. which was near equivalent to the contrast echo, which was 99%. So despite the fact that all of the examiners were the examination were tailored for LV thrombus evaluation, non-contrast echo yielded limited sensitivity, 35%, which remains suboptimal with the use of contrast echo at 64% sensitivity. This retrospective study of more than 300 patients with ischemic heart disease had surgical and/or pathological confirmation of presence or absence of LV thrombus in a subset of more than 160 patients who underwent MRI, TTE, and TEE, all within 30 days of their confirmation procedure. There was 48 patients with confirmed LV thrombus and 112 patients with confirmed absent thrombus. Delayed enhancement MRI with cine-MRI support correctly identified 42 out of the 48 confirmed thrombus and 111 out of 112 confirmed absent thrombi, with an overall sensitivity of 88% and specificity of 99%. In comparison, TTE correctly identified 11 patients of the 48 confirmed LV thrombi and 108 of 112 confirmed absent thrombi, with an overall sensitivity of 23% and specificity of 96%. And TEE correctly identified 19 out of the 48 confirmed LV thrombi and 108 of the 112 confirmed absent thrombi, with an overall sensitivity of 40% and specificity of 96%. How about CT scan? So all data suggests sensitivity of 80% and specificity of 100%. These data comes from an old studies in 1982 and 1989 to compare TTE, CT, and MRI in patients with LV aneurysm who are going for surgery. And also this was reported in 2 case reports, and it showed the utility of CT to detect LV thrombi as better than TTE. It also can detect small LV thrombi. A high density difference between the thrombus, blood, and myocardium can lead to a good contrast between the structures. The contrast and radiation exposure is limiting the use of CT scan. However, and the data from the CT use in left atrial appendage studies to detect thrombus, the reported radiation dose was as low as 0.4 millisievert. So for the management in this talk today is divided into 2 parts. The first is the prophylaxis for the LV thrombus in patient with LV akinesis or dyskinesis. And the second part is about the management of established LV thrombus. And I will have to go against the norm and mention what the guidelines said first, because there is a new evidence since the publication of these guidelines that support one approach over another. And on this slide, there is a summary of the main guidelines since 2013. In 2013, the ACC and AHA guidelines recommendation was the anticoagulation may be considered in patients with STEMI with anterior apical dyskinesis or akinesis, and the target INR 2 to 2.5 for 3 months, and the level of evidence of this recommendation was 2B. In 2014, the AHA and the ASA stroke prevention guidelines recommendation was the treatment with vitamin K antagonist may be considered in patients with ischemic stroke or TIA in the setting of acute anterior STEMI with anterior apical akinesis or dyskinesis, and the target INR 2 to 2.5, and the duration of therapy is 3 months. And again, the level of evidence was 2B. There was no recommendation provided by the recent AAC guidelines, and the Canadian guidelines in 2018 recommendation was the routine use of triple therapy should be avoided because of the weak evidence for the prevention of LV thrombi. In the prophylaxis in 2015, Dr. Lemay and our colleagues here at the Heart Institute published the first clinical trial to investigate the prophylaxis use of warfarin for LV thrombus post-anterior MI. And the question of the study was to determine the benefits of adding oral anticoagulation therapy in patients with anterior STEMI and with a left ventricular apical akinesis or dyskinesis after primary PCI. The study ran from 2004 to June 2010. A total of 838 patients with anterior MI were screened. They included only eligible patients, and they have a total of 460 patients for the study. 130 were discharged on warfarin therapy, and 329 were discharged without warfarin therapy. And their clinical exclusion criteria was an excellent criteria. In the warfarin, if the patient is in warfarin in the time of the admission, they were excluded. Atrial fibrillation, history of AFib, mechanical heart valves, bypass surgeries on the same admission, bleeding before echo, stroke before echo, history of intracranial bleed, death within 72 hours in the setting of ongoing shock or cardiomyopathy, and they excluded 121 patients by clinical exclusion. And by the echocardiography exclusion, they excluded 257 patients who had already have LV thrombus if they have absence of apical akinesis or dyskinesis, if the study was done more than 7 days after admission, and if the study not performed or suboptimal during the admission. And the echo assessment did regional LV function using a 16-segment model as recommended by the AAC guideline, and this model consists of 6 segments at the base and 6 segments at the mid ventricle level and 4 at the apex. Each segment was analyzed individually and scored on the basis of the motion and systolic thickening using the recommended scale, normal or hypokinesis, hyperkinesis 1, hypokinesis 2, akinesis 3, dyskinesis 4, and aneurysmal as 5. And at least one of the 4 apical segments needed an individual score of 3, 4, or 5 to meet the study inclusion criteria. Their primary outcome was composite of net adverse clinical events, consisting of all-cause mortality, stroke, reinfarction, and major bleeding within 180 days of the indexed TTE. And what they found that there was a complete follow-up was available in 99% of the patient population. And the main finding was compared with in patients with who were not prescribed warfarin, patients who received warfarin had a higher rate of NACE, the primary outcome at 180 days, 14.7% versus 4.6%. The rate of death was higher also in the patients who received warfarin, 5.4 versus 1.5 in the patient who did not receive warfarin, as well as the rate of stroke was also higher in the warfarin arm, 3.1 versus 0.3 in the patient population who did not receive warfarin. The need for blood transfusion was higher also in the warfarin group, 7.8% compared to 1.8% in the non-warfarin arm. And the 2 patients in the warfarin group versus none in the non-warfarin group experienced hemorrhagic stroke. And there was no difference in the rate of the reinfarction between the two groups. So this study concluded that the addition of warfarin to prevent thromboembolic complications in patients presenting with anterior STEMI treated with primary PCI was associated with more adverse clinical events compared with patients who were managed without warfarin therapy. So this summarized the guidelines recommendation for the management of established LV thrombus from the guidelines from 2013 until the most recent guidelines in 2018, and the American the ACC guidelines recommendation was the anticoagulation with vitamin K is reasonable for patients with STEMI and asymptomatic LV mural thrombi to target an INR of 2 to 2.5 for 3 months in addition to DAPT, and the level of evidence was 2A. The stroke prevention guidelines recommendation was a class 1C to treat with vitamin K antagonist in most patients with ischemic stroke or TIA in the setting of acute MI, complicated by LV thrombi, to target an INR of 2.5, and the duration of therapy was 3 months. The EC guidelines in 2017 recommendation to consider oral anticoagulation guided by repeated echo and with the consideration of bleeding risk and need for concomitant antiplatelet therapy. They did not provide specification about what type of anticoagulation to use, and the level of recommendation was 2A. And most recently, the Canadian guidelines recommended in patients with established LV thrombus who undergo PCI for an ACS or non-ACS indication, they suggest an initial regimen of triple therapy with aspirin, with clopidogrel, and anticoagulant without specification of what type of anticoagulation to use, and the duration of therapy more than 3 months up to 1 year, and the decision after that is left to the clinician and the imaging finding. So, is there a benefit of anticoagulation in patients with established LV thrombi? In this retrospective study of 1,800 patients with anterior MI, they investigate the incidence of systemic embolism and the association between anticoagulation and embolic or bleeding events. And this Kaplan-Meier analysis of the incidence on the left side of the screen showed the incidence of systemic embolism was significantly lower in patients with the time in therapeutic range, or TTR, more than 50% of the time than those with a TTR less than 50%. And the rate was 2.9 versus 1.8. On the right side of the screen, there is no significant difference in major bleeding events defined as moderate or severe or life-threatening according to the Gusto bleeding criteria between patients with time in therapeutic range more than 50% and less than 50%, 8 to 9% in both groups. So, DOAC versus vitamin K. This is a very interesting topic these days, and DOAC have been a breakthrough therapy for adults with non-valvular AFib and venous thromboembolic disease, for which these drugs have been approved by the FDA. But warfarin remains an important and the only therapy for patients with valvular heart disease patients, because DOAC failed to show any benefits in this population. The ease of dosing and the lack of requirement for dietary restriction, daily monitoring, combined with the strength of data in AFib and venous thromboembolic disease, makes the off-label use of DOAC a tempting approach. And in this slide, and I apologize, it looks a busy slide, a multiple case series of DOAC investigated the efficacy and safety of DOAC in patients with LV thrombus and showed the LV thrombus resolution rate was with DOAC ranging from 80 to 100%, with no significant difference with regard to stroke or systemic embolism. The red velvet. This retrospective study was published last year in JAMA to investigate the off-label use of the direct oral anticoagulant compared with warfarin for LV thrombi. And the outcome was their question to answer was the outcomes associated with direct oral anticoagulant versus warfarin in patients with established LV thrombi. A 3-center cohort study was performed, identifying 514 patients with LV thrombus in echo between October 2013 and March 2019. And they have a total of 514 patients with LV thrombi. 300 patients received warfarin, 185 received DOAC therapy. And the DOAC of choice was apixaban in 76% of the patients, and rivaroxaban was 24%. They have a median follow-up of 350 days, and their main outcomes and measure was clinically aberrant stroke and systemic embolism. And this table shows the baseline characteristic of the patients, and the groups were relatively well matched overall. But there was a few confounders in the DOAC groups, which include there was more venous thromboembolism cases, and there was more AFib patient as well, which meets actually statistical significance, and also nearly twice as many patients with protruding and pedunculated thrombus in DOAC arm, but that did not meet the statistical significance. So this Kaplan-Meier's survival curve, there was a total of 54 cases of stroke or systemic embolism events, consisting of 36 ischemic stroke and 18 systemic emboli. And of the 54 systemic emboli or stroke events, 17 occurred among patients who were taking DOAC, and 14 in patients who were taking warfarin. On a multivariable analysis, anticoagulation type, DOAC versus warfarin, and prior stroke or systemic embolism remain significantly associated with stroke and systemic embolism. Thrombus mobility, AFib, and venous thromboembolism history was not associated with increased risk of stroke or systemic embolism. And oral anticoagulation types or use was not associated with thrombus resolution as well. So they have a significant finding, which are there was 1/3 of the patient had no echo to confirm LV resolution on follow-up, and 8.7% of the patients with confirmed resolution suffered a stroke or systemic embolism within 30 days of the echo confirming the resolution, and 9 stroke and systemic embolism among patients being treated with oral anticoagulation within the first 3 months, and another 22 events in 3 months to the end of the study. And again, like the anticoagulation type was not associated with thrombus resolution. These findings are limited by the lack of randomization and by the retrospective nature of the analysis. However, I think the finding argue against the assumption of equivalence of DOAC and warfarin for LV thrombi before an outcomes can be compared with more like large prospective studies. In the last AHA meeting last year, the first clinical trial to investigate DOAC versus warfarin was presented, and it was not published until the time of this presentation. And I apologize, most of the data was extracted from their presentation at the AHA meeting, and they called it the no LVT trial. So it's the first randomized controlled study to assess different oral anticoagulation in the treatment of LV thrombus. It's a prospective, open-label, multi-center, randomized controlled clinical trial. And the patients were recruited from 5 tertiary hospitals in Egypt and Bulgaria. They have a total of 79 patients. Their inclusion criteria is evidence of LV thrombus on TTE. The exclusion criteria was creatinine clearance of less than 50, history of AFib, history of DVT or PE, other indication for anticoagulation, and they treated the patient with rivaroxaban 20 milligram for the duration of the study, or warfarin with a target INR of 2 to 3 for the duration of the study. Their primary outcome was resolution of LV thrombus on TTE. Their secondary outcome was stroke and systemic embolism and major bleeding. So at baseline, there was 39 patients in the DOAC arm and 40 patients on warfarin arm. And this trial was not a STEMI trial, and it included all LV thrombus patients. And the etiology of the LV thrombus in the DOAC arm was ischemic in 84%, and 12% was idiopathic. The etiology of LV thrombus in the warfarin arm was ischemic in 72% and of the patient, and 27% was idiopathic. And these differences did not meet statistical significance. So this trial showed that in comparison to dose-adjusted warfarin, rivaroxaban had significantly higher LV thrombus resolution at 1 month follow-up. However, there was no significant difference between both groups at 3 and 6 months. And rivaroxaban also had a significantly lower rate of stroke in comparison with warfarin at 6 months follow-up, without an increased risk of major bleeding. And this graph also showed the primary outcome, showing no difference in thrombus resolution beyond the first month between the anticoagulant type. So what about the Heart Institute data? So this data represent patients with from 2004 to 2018 who presented with anterior STEMI. They all underwent primary PCI within 12 hours of presentation. There was a total of 54 patients, predominantly male, relatively younger, with mean age of 57. Smoking and hypertension are the commonest modifiable risk factors in our LV thrombus data. All patients were revascularized within 12 hours of symptoms onset, and the mean time from symptoms onset to balloon time was 4.2 hours, and the door to balloon time was less than 2 hours. 50 patients received stent, and 3 underwent a bypass surgery. There was 3 patients in total who were discharged on DOAC, and there was 1 patient on rivaroxaban and 2 patients on apixaban. Warfarin was the anticoagulant of choice for the majority of the patients, and 46 patients were discharged on triple therapy, and Plavix was the P2Y12 inhibitor of choice with anticoagulations. And all the patients who had LV thrombus after anterior MI in our database were discharged home after a mean of 9 days of hospital stay. There is 2 stroke in hospital, 4 cardiogenic shock, and 4 major bleeding during hospitalization. So our data for LVT post-anterior STEMI extend from 2004 until 2018. And out of the 54 patients we have, there was 5 deaths on follow-up, 6 strokes, and 4 patients who needed blood transfusion. I will elaborate more on the following slides regarding the timing of these outcomes. So there was a total of 5 deaths on follow-up, and the time on the x-axis represents years. And there was 2 deaths in the first year, particularly in the first 2 months post-discharge. And there was another death just after 2 years post-discharge and 2 deaths 5 years post-hospital discharge. For the stroke outcome, there was a total of 6 strokes in follow-up, and there was 3 strokes in the first year. 2 were in the first 2 months post-discharge, and 1 in the 6 months at the 6 months marks. And there was another 2 strokes at 5 years post-hospital discharge. And the etiology for these strokes seems to be cardioembolic based on the neurology note. However, we don't know if these patients were using anticoagulation at the time of the stroke or not. And we don't have data yet regarding the resolution of the LV thrombi. A total of 4 patients who received blood transfusion on follow-up. There was 1 patient who needed a blood transfusion in the first month post-discharge. There was another 2 patients who received blood just after 2 years post-discharge, and 1 at 13 years post-discharge. And again, this is a preliminary data, and we are working on extracting more information and data regarding the etiology of death, stroke, and for the how long these patients were treated with anticoagulation. So to conclude this presentation, there is a few take-home messages. One, like LV thrombus is a result of multiple factors, and not only the LV dyskinesis or akinesis, but subendothelial tissue injury and persistent hypercoagulability as well. Anterior STEMI and reduced ejection fraction are an important predictor of LV thrombus formation. TTE remained the first line of imaging modality to investigate for LV thrombi. Contrast TTE and cardiac MR to be considered based on local availability and resources. And it provides higher specificity and sensitivity. There is strong evidence that showed the use of anticoagulation for the LV thrombus prophylaxis is harmful in patients with LV akinesis or dyskinesis without LV thrombus. And I think patient preference is an important part of the decision making for the LV thrombus management, giving the conflicting evidence of DOAC versus warfarin. And there is few questions left to be answered. What is the utility of CT scan in detecting LV thrombus? And if we can use that for follow-up? And what are the evidence to support the safety of vitamin K use in LV thrombi? And how safe is DOAC compared to vitamin K antagonist? And how long to treat LV thrombus? How long the follow-up should be? And what are the best imaging modalities for follow-up? Thank you, everyone, and I'm open to comments and questions.
Thank you, Saad. That was a great overview. There is one question from the audience, and then maybe we can open it up to you and Dr. LeMay and Dr. Froschel, who are on the presentation as well, for comments. So the question from Dr. Golian is, do you think the issue with no benefit with prophylactic use of systemic oral anticoagulation to prevent thrombus formation is the duration of therapy that was provided in the studies? And the second part of the question is, with the presence of DOACs and lower risk of bleeding, do you think we should repeat short duration prophylactic use of triple therapy in high risk patients?
So for the first part, I don't think I have a good answer for that questions, but I think without an established diagnosis, we have of LV thrombi, we have more than like 90% of this population might not have LV thrombi, that we are committing them to anticoagulation and exposing them to the side effects of anticoagulation plus the triple therapy they have. So I think, and maybe Dr. Lemay can weigh in, but I don't think the duration of therapy could be a factor for the outcome. For the second part of the question was the DOAC use, and if we can repeat that in high-risk population. I think that's a good idea if to do that, especially with a small dose of either rivaroxaban or apixaban. It was shown in COMPASS trial, like small dose have a good outcome with other antiplatelets. And I think that's doable in high-risk patient with anterior MI and LV akinesis and dyskinesis.
Dr. Lemay, do you have a comment?
Yeah, I think that the recent questions regarding the DOACs have given us a chance to relook at LV thrombus, particularly in the case of STEMIs. And there's an explosion now, I think, of questions that arise out of the appearance of the DOACs and the consideration of DOACs. First, I think that one important thing that we've learned is that we're probably doing, the transthoracic echo is probably the most useful, accessible modality in terms of the documenting the presence of thrombus, and there may be some exceptional patients where from a practical point of view, you may want to get CMR, get CT, but I think for most of the patients, we should be doing echoes. And then the question arises, and I've seen this many times now, that we do the echo when the patient comes out of the cath lab, and I think it's really too early to look at that patient and make a decision on whether or not that patient's got an LV thrombus. It's okay to say that the LV function is normal. If it is, that's great. But if the patient has a dyskinetic or akinetic apex, it's had a big anterwall infarct, that echo needs to be repeated. The study that we did, the average time was about 72 hours, 2 to 3 days afterwards. So doing it the same day or day afterwards is probably not the right thing to do. The other thing that I've learned in following a lot of these patients is that the duration of treatment, I think, is something that we need to look at much more carefully. I think a lot of these studies, like the recommendations of 3 months or 6 months, I think they're based on evidence level C, and I think these patients are particularly high-risk patients. And I think we need to repeat the echoes afterwards, and we've seen cases where the thrombus was gone, totally gone, and that sounds very reassuring. But I think that when you repeat the image afterwards, a little bit, maybe a couple of months afterwards, and the thrombus is back. So what do you do with that patient now? The thrombus is back. And some people would advocate that maybe for some patients that as long as the LV function is really poor in terms of the apex, that we should continue maybe anticoagulants indefinitely. And then, when you go through the charts on these patients with LV thrombus, and the ones that had stroke, you kind of see, well, the neurologists kind of conclude they're embolic. So I have concerns that these patients with LV thrombus, we should be following them. We should be doing serial follow-ups on these patients. And then that speaks to collecting data. And if you're going to find out, like if you look at the randomized trial there, tiny amount of patients, like 80 patients, really hard to be able to make anything out of 80 patients. That's just provocative. The frequency of LV thrombus is relatively small. So I think that collecting data and getting good data registry, and then going forward, we'll learn more about what the DOACs, we have data now that's complete to 2018. And then when we get up to date on the remaining database, we'll be able to tell you a little bit what DOACs do from a registry point of view. So I think collecting data and following the patients, and the Heart Institute is kind of lucky because when you look at those patients, they have had a ton of echoes. And then it'll be, Saad's got a great project there, and he did it. This was a very good presentation. It gives us some perspective of where we are going to be going with the management of LV thrombus. And when you bring on the DOACs, it becomes, there's so many factors to consider. Are you going to do dual antithrombotic therapy or triple therapy? Which DOAC are you going to use? Which dose of DOAC are you going to use? Are you going to use the full dose? Are you going to do like pioneer dose and reduce the dose? Are you going to combine it with clopidogrel? Are you going to combine it with ticagrelor? Are you going to drop the aspirin? So a lot of questions. And a lot of research needs to be done.
So, Michelle, do you think that we should be protocolizing when the echoes are performed post-anterior STEMI, since that seems to be the highest risk population?
But,
because right now there's a large degree of variability on when those studies are performed.
So I think that we've learned from the previous paper that we did them about day 3. So an anterior wall STEMI, for most of them, are not going home within 48 hours. Like if you look at anterior MI, one, if they come in they're already higher KILIP classification and they've got a big CK rise and it's a big anterior infarction, the likelihood is that that patient's a keeper. If you do a pocket echo early on and you see dyskinesia, that patient should probably get a formal echo done at day 3, day 4, and not on day 1. And I think that for those where you still remain concerned about the patient, where, you kind of say, well, you know what, that was a big infarct. I remember Don Beelan saying, there are some patients that you may need to keep in the hospital for a longer period of time. That patient with a good sized infarct that came in KILIP 3, that patient, the concern is like late VT. Well, there may be later LV thrombus formation in that patient. If that patient is in the hospital, it may be reasonable to repeat that echo. And I think the echo is a great tool for surveillance. And I think that if you're going to take them off the drugs, you need to repeat the echo and find out what's going on. We've had one, for example, that was on, this guy was on DOAC, and then he had extensive polyps. So they took him off his DOAC, and because they did such an extensive resection, they decided not to restart the DOAC till a couple of weeks later instead of restarting him earlier, and the guy had a stroke. So I think that we need to be very vigilant. I think these are a higher risk population, and I think we need to have good surveillance and keep them close to the Heart Institute, keep following these patients.
So another question, Saad, from Dr. So. Do you think we are underreporting LV thrombus with our current practice based on our current imaging protocols?
So I don't think,
maybe you try that one.
So I don't think we are underreporting. Sometimes it's the timing, and the problem. This can extend up to 6 months based on the data that I presented, and there was also some reports of LV thrombus forming even after 1 month of the myocardial infarction. So I don't think we are underreporting. I think it's the timing always is different from one patient to another, and it's hard to generalize in when and what time we should do echo. But I think a good approach, and I think this is Dr. Froschel approach, and everyone, most of the cardiologists at the Heart Institute, to do echocardiogram after presentation, and then another one in 3 months, just to make sure there is resolution. There's no LV thrombus, and there's no wall motion abnormality. And there's a few patients who had LV thrombus resolved, then they had recurrence of that on follow-up. And different imaging modalities also we have patients who had no LV thrombus in echo, but we detected that on cardiac MR. So it's really a matter of when and what imaging modality to use, and I think that's the main question that needs to be answered. And maybe Dr. Froschel, you can add a few things to this.
Sure, I'm cognizant of the time. Saad, you did a very good job. That was a really good overview. I agree with Michelle and what you just said, Saad, that I've had 3 patients in my own practice, I've discussed this with Michelle many times, who have had a recurrence of LV thrombus after resolution on anticoagulation. And 1 presented with stroke, 2 were found incidentally on follow-up. To Michelle's point. And so what I do, as you know, is patients who've had an LV thrombus, who have persistent apical wall motion abnormalities that are important, either akinesis or dyskinesis, I continue them on a NOAC lifelong. I do have one question for you, Saad. At the conclusion, your last slide, well, I'll give you a scenario. Anterior STEMI, apical dyskinesis, a 1 by 1 centimeter apical thrombus. In someone who got stented, 65-year-old woman who got stented, what would you use as your anticoagulant? You're looking after the patient, you're FRCP cardiology.
Yeah, so like that's really a difficult question to answer. So I think I cannot say the safest decision, but the practice that's been going for many years is warfarin is the anticoagulant. But the question now, can I start DOAC? I think, again, discussing that with the patients is very important. I think providing the information that we have to the patients and having an informed decision, I think that's what the most important step we need to do in the decision making for LV thrombi, choices of anticoagulant.
Okay. All right, so you're the patient. What would you want?
I would want DOAC, to be honest.
Yeah, so I mean, I'm supportive of that. I do think what we've been doing, extrapolating responsibly, and then I think this most recent data is supportive. Obviously, we need more, and the studies I hope are being done, and your work will be really important, I think, to contribute to the knowledge. But I think that's a very responsible thing to do, all things considered. Although you're right, the jury isn't entirely. The verdict's not in.
So can I chime in, Mike? Would you add clopidogrel or ticagrelor? Would you add aspirin or no aspirin? The patient's been stented.
Yeah, so it depends on the extent of stenting and the complexity of stenting. I often use triple therapy for a period of time, as I think you know. And it's usually the duration, my inclination to use triple therapy for a longer time would guide the decision between clopidogrel and ticagrelor. Like you said, it's complex. Derek so quotes the number of possible combinations in antithrombotic therapy. So, you know, it's exciting times because if we knew all the answers, life would be boring. So this does leave room for some clinical judgment and patient preference, like you said, Saad. Great job today.
Great job.
Thank you.
Great, thank you, everyone. I'd like to thank Saad for presenting today and thanking Dr. Lemay and Froschel for joining as moderators. Next week's rounds will be by Dr. Robert Avram, one of the PCI fellows. His title is Applications of Artificial Intelligence in Cardiology. So thank you for joining us today. Have a good week, and we'll see you at rounds next week.